welcome you to this Global Patients Perspective Roundtable, navigating telehealth, telemedicine, and embracing shared decision making. This is the first in a series of 4 roundtables sponsored by GSK. As appropriate, the presentation and discussion will include the influence of COVID-19 and the issues related to the global health equity. The Global Patient Perspective Roundtable series is a significant component of IGCS efforts to contribute to the global need for vetted, constructive, region and population-specific information and guidance. Thank you so much for joining us today. First of all, I would thank to Daisy Scroggins, our Director of Global Outreach and Engagement, for her outstanding and her great support to patients, caregivers, families all over the world. And thanks to Ross Glasspool for helping me as a guest panelist in this session. Let me introduce our incredible panel. Gwen Darian, Executive Vice President, Patients Advocacy and Engagement, National Patient Advocate Foundation and Patient Advocate Foundation, United States. Miriam Mutebi, Breast Surgical Oncologist and Assistant Professor of Surgery, Aga Khan University Hospital, Kenya. Karen Begai Wilson, Cervical Cancer Survivor and Advocate, a member of Navajo Nation, United States. Noriko Fujiwara, Oncology and Research Nurse, IMSUT Hospital of the Institute of Medical Science, University of Tokyo, Japan. Graciela Zibetti Dalmolin, Medical Oncologist, Beneficencia Portuguesa de São Paulo Hospital, Brazil. Kimlin Hashing, Professor and Founding Director, Center of Community Alliance for Research and Education, City of Hope National Medical Center, United States. This is a truly outstanding panel of presenters who will provide insight and guidance on telehealth and telemedicine and shared decision-making from the various regional and other perspectives. Also on screen are Mary Aiken, the IGCS CEO, and Daisy Scroggins, our milestone for global advocacy. Well, let me start because the agenda is very full. Friends, I will provide a little perspective on these important topics from my perspective in Italy. And at the end of session, we will have the time for question discussion. Access, equity, quality, and cost effectiveness are the key issues facing care worldwide in both developed and developing countries. Modern information and communication technologies such as computers, internet, and cell phones are revolutionizing how individuals communicate with each other, seek and exchange information, and enriching their lives. These technologies have a great potential to help address contemporary global health problems, especially during this difficult period. We start with the differences between telehealth and telemedicine. Telehealth includes a broader range of remote healthcare services. Example of telehealth includes health education services, remote monitoring of vital signs, ECG or blood pressure. It includes remote doctor-patient consultation, telemedicine. Recognizing that there is no one definitive definition of telemedicine, the WHO has adopted from 2007 this broad definition. The delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers, all the interest of advancing the health of individuals and their community. 4 aspects are generated by telemedicine. Its purpose is to provide clinical support. It's intended to overcome geographical barriers connecting users who are not in the same physical location. It involves the use of various types of information and communication technologies. Its goal is to improve health outcomes. Telemedicine application can be classified into 2 basic types according to the time of the information transmitted and the interaction between the individuals involved, be it health professional to health professional or health professional to patients. It must be taken to ensure that telemedicine will be deployed intelligently to maximize health services and optimal quality and guarantee that profit interests do not deprive citizens access to public health services. It's imperative that telemedicine be implemented equitably and to the highest ethical standards to maintain the dignity of all individuals and ensure that differences in education, language, geographical location, physical and mental ability, age, and sex will not lead to marginalization of care. Collaboration and participation and capacity building are fundamental to the success of sustainability of telemedicine initiative. So it must be taken to ensure that telemedicine will be deployed intelligently to maximize health services and optimal quality and guarantee that profit interests do not deprive citizens access to public health service. So the principal barriers, the most prevalent barrier to the implementation of telemedicine program globally is the perception of cost of telemedicine is too high. Developing countries are more likely to consider research issues such as high cost, undeveloped infrastructure, and lack of technical expertise to be barrier to telemedicine. In addition, most challenging of all are linguistic and cultural differences between patients, particularly those unserved and service provided. Developed countries are more likely to consider legal issues surrounding patient privacy and confidentiality, competing health system priority, and the risk of medical liability for the health professional offering telemedicine services. In particular, In particular, the most prevalent barrier worldwide is the cost, while in Europe is the legal issue. In order to overcome these challenges, telemedicine must be regulated by definitive and comprehensive guidelines which are applied widely, ideally worldwide. Patients Association can help in overcome obstacles, collecting the thoughts and reporting problems encountered by patients. In this way, they can create a connection with other leaders and patients worldwide. In Italy, the most important barrier is what the patient thinking. Doctor, how can cure me if you can't touch me? Italians are really suspicious about telemedicine. Patients are not so comfortable with the situation where timely assessment is not possible when doctors are not able to examine them directly. Especially in this devastating period in which we face to face with COVID-19 disease, in order to continue best standard of care for our patients, minimizing the risk of infection, we should encourage in our routine the telemedicine for follow-up visit, for evaluating the toxicity in research trial. Unfortunately, in Italy, in the first 5 months of COVID, about 1,400 million fever screening exams were carried out compared to the same period in 2019. Estimates indicates that in 2020, there were about 2,100 missed diagnoses of breast cancer and almost 1,000 for colorectal cancer, and about 1,700 for precancerous or cancer lesion lesion of the cervix. So be careful. We don't stop our work. It's difficult, I know. But patients need to continue to be treated, care, and addressed to the best treatment choice. Finally, telemedicine can help us for improving care and educational through webinar, roundtables, teleconsultation, if not possible in person, educational programs involving physician, general practitioner, and patients. I conclude, remember you, we don't forget, we not just cure, but care the patients. And this is possible thanks to doctors, researchers, nurses, patients associations. This is the website for the health equity, for the statement of IGCS. Thank you very much for your attention. And next, I will turn the session over to Gwen Darien. Okay. And Gwen Darien from the National Patients Advocate Foundation in the United States. Gwen, please.
Thank you so much for having me. I'm thrilled to be part of this conversation and part of this global conversation. We are facing global challenges, and we don't often enough, or at least I don't often enough, have conversations with my colleagues across the world. So I'm going to, my name is Gwen Darien. I've been working at patient advocacy for almost 25 years since my first diagnosis of cancer. I'm a 3-time cancer survivor. Actually, my last cancer was a gynecological cancer, endometrial cancer. And I started working in cancer advocacy because I wanted to both change things that change the experience and the outcomes for people who came after me, and also find a community with whom I could work on changing these outcomes and really take action. I was a young adult cancer survivor, and now I'm not a young adult cancer survivor, but that was really the motivation there. But as I was explaining to everybody a little bit earlier, the through lines of the work that I've been doing for the past 24 years have really been ensuring that everybody has access to equitable, quality, affordable healthcare, and that patients are at the heart of healthcare through skilled communications and shared decision-making. So I'm going to focus a little bit more on some of that, but also within the context of what we do at the National Patient Advocate Foundation and the Patient Advocate Foundation, which is we provide social needs navigation, primarily social needs navigation and some clinical navigation for low-income, traditionally marginalized populations who are having trouble accessing care. So this is the theme of the team that our team, Ask, Listen, and Co-Create. And this is something that we think about every time we undertake a project, every time we talk to each other, every time we work with the community. And underneath that is a picture of 5 of our amazing advocate volunteers, including Nurse Tammy Taylor, who is in the red jacket there. I've worked with many, many nurses throughout my advocacy time. So I just want to also shout out to nurses. This is what I do is, this is sort of the summary of what the difference is between the Patient Advocate Foundation and the National Patient Advocate Foundation. And I'm on both teams, as is my team. And Patient Advocate Foundation is the direct patient services part of our organization. We work at helping one patient at a time and one community at a time. And last year, in this year of COVID, we've served over 170,000 patients who had trouble with access to care. Like the United States itself, most of our patients are insured, but everybody is underinsured. And then the National Patient Advocate Foundation works at the intersection of direct patient services and system change. So we take what we learn from the individual patients and the communities with which we work at PAF and create initiatives and projects that are based on what we learn about barriers in access, but also look at not just the barriers, but look at the opportunities to make change. So just to give a little context, this is what drives everything that we do. These are our core beliefs. So to fulfill our commitment to equitable access to affordable quality healthcare, this is what we believe, that patients play a key role in driving systemic changes. Patients are part of the change process, not simply objects of that change. And I will say that for many of my colleagues and friends and me, this is what drove us to this. We felt like objects of care as opposed to partners in care. Patients and their providers co-create health and healthcare planning that meet clinical objectives, life goals, and individual values. And this is the other thing that is really critical to everything that we do and everything that we do with all of our partners, is that this is a co-created plan. And when I say plan, I guess in the United States, some people think of insurance, but I'm talking about care, health and healthcare planning. We also are very clear that we talk about healthcare, not just clinical care, because healthcare is what impacts, it is the more holistic way of looking at what we're doing. Clinical care treats the disease, health care treats the person and the family and the community. So these are the foundations of patient advocacy and engagement that facilitate shared decision-making. We elevate, we integrate, and we iterate. So we elevate issues and solutions of the patients and the community served, and that's part of our asking and listening. We integrate patient life experience and social and political context into every aspect of decision-making. So that's also part of our co-creating. And we are at a very specific moment in our socio-political context, where I think there's both a barrier to doing this and also an opportunity to talking about things in a more direct way than I think we've talked about before. And we iterate, which means we learn by implementing a learning system, a feedback loop, an evaluation and continual improvement. Because if we do not learn and if we do not change, then why should we ask and why should we listen? So these are our pillars to achieve equitable access to affordable quality healthcare, which is in the center: skilled communications, quality improvement and evaluation, safety net service at navigation or social needs navigation, and shared decisions. This is just a very brief description of what we do at National Patient Advocate Foundation. We advance personalized healthcare. We assure access to affordable quality healthcare. We advance shared decision-making. We help patients become better self-advocates if they want. We ask people what they want before we work with them to achieve their goals. And we work to co-create a culture of health. We do this at the individual, community, and policy levels. And this is a slide from one of our policy consortia, which on conversations about cost of care. So we also have spent a tremendous amount of time on looking at cost of care and financial toxicity, how we integrate those conversations about financial impacts of healthcare to improve health outcomes. These are 4 more of our fantastic advocates, and this was during a conversation and a patient advocacy convening around these issues. And there are many, many parts of this conversation. And financial toxicity, I'm not sure how much that has taken hold as a concept and globally, but in the US, we look at it, and it started mostly in oncology, and we know about financial impacts, but we look at financial toxicity as one of the side effects of treatment. And everybody that we treat has experienced financial toxicity. Everybody that we treat, we don't treat. Everybody that we help and that we help get through there and achieve quality healthcare has had to, most people have had to choose between, do they feed their family or do they take their medication? How do they get, we're going to hear later about transportation. How do they get to their appointments? How do they travel? Some people have to travel states. Some people can't even get to the pharmacy. So these kinds of issues are part of a holistic look at how we achieve a healthcare that meets the needs and helps facilitate the outcomes that are meaningful to patients. So I want to thank you very much for listening to this, for this introductory presentation. I very much look forward to our conversation. Thank you.
Thank you, Gwen, for an enlightening presentation. Our next panelist is Miriam Mutebi from Aga Khan University Hospital in Kenya. Miriam, please.
Good evening from chilly Nairobi now. My name is Miriam Mutebi and I'm a breast surgical oncologist, and happy to be part of this conversation. And over the next few minutes, I intend to just touch briefly on our changing cancer demographics in Kenya, talk briefly about the role of telemedicine and telehealth here, and then reflect about our shared decision-making processes all through the lens of the current ongoing pandemic. We've seen, I would say, an increase in the number of patients diagnosed with cancers. We've gone from about 24,000 patients diagnosed in 2012 to just about 6 years later by 2018 to about 42,000. And our patients typically are diagnosed 10 to 15 Western countries, and they tend to be diagnosed, the majority. And this is in the background of the lack of reason behind, the deeper dives into reason behind, like Gwen shared, that patients frequently have to pay out of pocket for their health-seeking behavior, which frequently results in catastrophic health expenditure. The National Hospital Insurance Fund does try to mitigate some of these costs, but this is further compounded by poor and dysfunctional health systems and referral patterns, where you see that patients may engage on average with maybe 2 or 3 clinicians before a definitive diagnosis is made. And this is further compounded by factors like culture, where there's myths and stigma around a diagnosis of cancer, and also given the fact that women are not the primary determinants of their health-seeking behavior in certain communities and may, for instance, require either permission or financial support from a partner or a spouse. Now, in terms of looking at telemedicine, I mean, we're not, telehealth has been something that's been very prominent in Kenya. Keep in mind that we have about, by 2017, the digital maps show that we had about 89.1%. Sorry, I think I'm going to move. I can just hear a bit of noise in the background. Sorry. And that has extended to about almost 97% mobile phone penetration by 2018, which is significant because that means we essentially have more people who have access to mobile phones than to running water and stuff. This is about, there's about 66% smartphone coverage, but the majority of patients are, majority of the population is well connected. And so in terms of looking at the spectrum of services, it ranges from the simple telehealth, as Daniela described, to, ANC visits, where they're getting updates on their antenatal visits, to more complex teleconsultations in more remote areas, all the way through to complex surgical procedures done remotely. Of course, with the pandemic, there has been an increase in fear and distrust of coming to the hospital. We've seen an exponential increase in the telemedicine and telehealth services, along with a concurrent increase in both apps and lots of available services, telehealth service, and even the rise of mobile pharmacies that are coordinated through the use of mobile phones, and we have motorbikes that are able to do deliveries for patients to their homes. However, looking at the effect that this has had, especially through the lens of the pandemic, we have seen that there has been some aspect of continuity of care, even in the face of the lockdown, even with the face of concurrent lockdowns where patients are not able to travel. And we've had an expansion in the patient navigator roles, where they've had to, take an increasing role in trying to follow up patients and encourage them to still continue their care. And of course, in terms of knowledge sharing, virtual tumor boards have expanded, and we've had to move our patient support services online. And I mean, there's been a bit of a mixed reception. A number of patients feel that there's a little more convenience. They don't have to travel long distances. Keep in mind that we're on average having people perhaps traveling over 300 kilometers to access their care. And they feel sometimes that, when there's 2 or 3 doctors sitting and discussing them, then it actually makes them feel important. And so they quite like it. And some of the patients have actually said, when we're in the clinic and the clinicians like just trying to clear the queue because they're really busy, they feel that sometimes just sitting down and having a chat with the oncologist at that time, they feel that the oncologist is more engaged and actually listening to what they have to say. However, this of course goes with the cost of the smartphones, the data equipment. You have to buy your data. Again, despite the high penetrance, that you have to look at coverage concerns. That's very sketchy across the country. And perhaps because the more we lean towards the more sophisticated tools, perhaps we are sort of looking at a worsening of disparities, because that in effect only increases access to people for those who can afford it. Similar to, as Daniela described, the Kenyan population also are invariably a little suspicious if you haven't examined them and suddenly expect to miraculously come up with a diagnosis. They're not convinced until you put your hand on it. And so even with the emergence of all these technologies, it's important concerns around safety of data and what's actually happening, who's monitoring what's going on, has led to a robust development over the last 10 years, I would say 20 years, by the Kenyan government to come up with a national e-health strategy that helps to determine the governance and building and implementation and integration of these systems into regular healthcare services. And so when we look at how the models around shared decision-making, we do recognize that it is a critical component of care, but the fundamental bit is ensuring understanding of the disease processes and treatment expectations. And you can imagine in Kenya, for instance, where you have over probably 42 languages, then you're having the challenge of, are we actually, delivering the message that we intend to deliver? We have a few pitfalls, I would say, around paternalism, where we sometimes we're I would say a system in transition, but for the longest time, doctors would literally come down from the mountain with 2 tablets, no pun intended, and tell you about your care. And as Africans, we're a very warm, very vibrant culture. There's a very strong sense of community, but it has a double-edged sword where sometimes women are not the primary determinants of the health-seeking behavior. So for instance, you would find that a lady requires to have breast surgery. She would like a breast conservation. And, 2-3 weeks later, there's a whole formal gathering of elders, and an older gentleman is coming in to say, we have decided. And, you're looking at who are you, but these are the important cultural considerations that we need to take in mind, especially when coming up with decision making. Because again, if the lady is not the primary determinant and she's not the one signing her own paycheck or actually having access to care on her own, then she's pretty much going to be going with what the party line says. And so it's important to recognize, especially as clinicians, that when dealing with vulnerable populations, because there's a lot of trust in I would say our public, that's becoming less, which is a good thing, I guess, because they're asking more. But it has been a potential for abuse earlier where there was a lot of misconduct and not necessarily too much scrutiny because of the absolute trust that people had in the clinician. So it's not a responsibility we take lightly. And so when looking at patient-centered approaches, I think it's important to address, have a holistic approach to it, address the effects of treatments, physical limitations, make sure that those are fully understood, and also address psychological concerns around uncertainty and body image. But I think key is patient education and empowerment, and encouraging them that we are partners in their health, but they are the primary determinants of their health-seeking behavior. And no conversation around patient-centered approaches can be held without, having real critical concerns about, the financial stability or the ability to access care, and using these strategies to effectively rehabilitate and reintegrate patients into the community. In closing, I would say telemedicine and telehealth is not it's not a magic bullet for dysfunctional health systems. Even as we sort of think about it and go along, there is a need to have these innovations and strategies go hand in hand with serious determined steps to increase access to care for patients. And I think a multi-sectoral approach is key to shared decision-making. We can't talk about shared decision-making without even discussing concerns around health literacy. We know from the literature that, about 50 million women girls currently, at least by 2018 in sub-Saharan Africa, are not in school. So if we're not empowering them, we're not educating them, then how can we talk about how their understanding and knowledge? Because you educate a child, you educate a girl, you educate a community. And so with patient care, education and empowerment initiatives do go hand in hand with providing equity and access and actually bringing our ladies and women and, populations to, I would say, financial independence. And pandemic considerations do offer opportunities, I believe, to, sort of go back to the drawing board, rethink our care delivery strategies and see what would be best going forward. So in closing, I do acknowledge that it does take a village. And I just want to thank the IGCS and GSK and more importantly, you, the audience, for this opportunity, and looking forward to an interesting discussion. Thank you.
Thank you very much, Miriam. Amazing presentation. Thank you. Please, attendees, add your question through the Q&A feature at the bottom of your screen, please. Now we will move on to Karen Beggy Wilson, a cancer survivor from the Navajo Nation in the United States. Karen, please.
Yes, thank you. I would like to thank IGS and others who asked me to be part of this presentation, Navigating Telehealth, Telemedicine, and Embracing Shared Decision-Making. This will be my Navajo survivor perspective. My name is Karen Begay Wilson. I am Navajo from, my family originates from New Mexico. I was born and raised and currently live in Brigham City, Utah. I come from a large family. I am married. I have 4 children and a lot of adopted and foster children as well. And on top of that, very busy with a lot of grandchildren. I was diagnosed with cervical and uterine cancer back in the mid-1980s. During my course of treatment, I lived in Montana, Utah, and New Mexico. My place of residence changed a few times due to lack of insurance. So I had to go where the help was. While down in New Mexico, I stayed with my sister and her family. Each would share their opinions with me, like my doctors and my treatment team. It was important to me to get input from my family. After all, the outcome would affect them as well. Not only did I receive medical attention, I was lucky to also receive mental and emotional assistance to help me cope with all that I was going through and the changes that would be coming. I was also lucky to have, and it was important to me, seeing a medicine man to help me prepare by cleansing and strengthening and balancing me before, during, and after treatments. Resources like telehealth and telemedicine are not widely available on my reservation, nor are they available on many other reservations across the country. Many are without the luxuries of electricity, internet, water, and even food. Many suffer without any connection to medical resources due to the lack of these things, and also transportation. Most people live out in the middle of nowhere, literally. And now, with the pandemic happening everywhere, It's even harder to get the medical attention they need. I found it hard to talk about cancer. It's just something that people don't talk about, like death. That's a tradition, a part of our culture. I have seen that during exams, a description would have to be given extensively because there is no word in our language for cancer. Whenever the word cancer came up, it was basically an indication that, well, death was knocking on our door. Not enough education reaches the people on our reservation, so they automatically think that nothing can be done for them. After my experiences, I decided to speak up for myself and my family to let them know that it's okay to talk about their health and cancer with their doctors, their healthcare providers. So much so that I became a spokesperson for a Native American outreach program at the Huntsman Cancer Institute in Salt Lake City, Utah. It is led by a very wonderful woman by the name of Phyllis Nassy. It is designed to help those with cancer find the much needed information and resources. I would like to thank everyone who has helped me through my cancer. It was a very trying and very learning time for me. Again, I would like to say thank you for Dicey and others who asked me to come and be a part of this, to present my experiences and to share with others who are going through same experiences. I hope this has helped others. Thank you so much for this time.
Thank you very much, Karen. What an extraordinary presentation, your life and your journey. Thanks to you for sharing with us. So now our next panelist is Noriko Fujiwara from Imsud Hospital of the Institute of Medical Science, University of Tokyo in Japan. Noriko, please.
Hi, I'm Noriko Fujiwara. I'm an oncology and research nurse who work in Japanese research hospital. Thank you for having me in this great program. It's my honor to attend here as one of the panelists from Japan. Today, I'm going to talk about our experiences from Japanese and nursing perspective during this pandemic. First of all, I'd like to explain about my role and the working area briefly. I mainly work for the research hospital of the University of Tokyo, Japan. My role of this hospital in the oncology nurse, palliative care, and hospice nurse, and the research nurse. And this hospital is one of hub institutes regarding translational research. So mostly have conducted early phase and small own trials. I also work for Saitama Medical University International Medical Center as an advisor of clinical research nurses and clinical research coordinator both. This hospital usually conducts big trials and phase 3 big trials. And I'm now and collaborate with doctors and patients in the gynecologic oncology research fields in Asia Pacific. So this is cumulative confirmed cases of COVID-19 by country. Compared with the US and India, Brazil, and other countries, Japan, fortunately, has more number of infected patients, but it's getting increasing the number of patients now. So COVID-19 had a big impact on research and the clinical setting in Japan too. And let's look at the situation in Japan. We had 3 peaks in the number of confirmed cases so far. Japanese government announced the state of emergency on 7th April until 25th May. And on early June, Tokyo alert was issued because Tokyo had highest number of infected patients. So Tokyo governor announced the unique alert as an early warning because of the risk of the infection re-spreading if people start moving around in large cities. But after the lift of alert, the number of infected cases had increased again. And in early April, the authority, the Japanese government, Ministry of Health, Labor and Welfare, notified to ease the regulation of telemedicine. And if patients don't want to and can't visit the hospital, we can ship the drug to patient home directly, even though it's a study drug. The pandemic has had a great impact on nurses and research professionals' work. The Center for Clinical Trials, Japan Medical Association, JMA, surveyed the impact on 154 academic sites, hospitals. According to this survey, there was little impact on new clinical trial contracts, but there was a significant impact on hospital visit by pharmaceutical company and patient also. In addition, 22% of hospitals stopped new recruitment for their research. Some patients didn't want to visit the hospitals because in Japan, local governors imposed restrictions on cross-prefecture, cross-state travel, which affected patient visit. For example, some patients refused to come to the hospital for their regular visit of the trials because some large cities such as Tokyo and Osaka and Hokkaido had a high number of infected patients. So if they move from Tokyo or the big cities, they would be asked to stay home for 2 weeks. About telemedicine in Japan, in 1997, the ministry stated that the first consultation with each patient should be conducted face-to-face only. But because of COVID-19, they modified their stance. And at the time, telemedicine used only for rural area and isolated district. But now we can use all over Japan. In 2018, telemedicine can be charged and established the guidelines. Over 10,000 hospitals and clinics use telemedicine in Japan, but telenursing is not same of the telemedicine by doctors. Japanese nursing phone call means just confirmation call and no charge to the patient. Telenursing is not systematized in nursing activity of Japan. Here is from OECD report about the percentage of population aged 65 or over years old in 2020. Japan is now highest aged society in the world. The COVID-19 pandemic has focused increased attention on social isolation and loneliness for all ages, particularly older adults and patients as the most vulnerable at risk segment of the population. Japanese working clinics have served as place of social connection because the Japanese people can access to healthcare service very easy and low cost. For example, Japanese government covered around 80% of medical fee for older adults. So National Center of Geriatrics and Gerontology and the Japan Geriatric Society recommended about reducing risk under staying home situation to public. People who lose their feeling of social connection lead to progress their frailty. The social this society showed the frailty domino like this. The National Center showed the activities, here. The National Center showed the activities which we can do even at home to keep their condition. Another point that I want to mention is that Japan has had a long-standing tradition of paternalism with regard to patient-doctors encounter. Edward T. Hall showed in his books Japan as the highest context society. He defined a high context society as one in which implicit messages in context are preferred in communication, and the direct expression tends to be avoided. In the Japanese clinical setting, the type of decision-making process in which the patient leaves the decision to her or his doctors has been termed in Japanese as the omakase entrusting style. However, now it's changed slightly. Japanese doctors try to facilitate discussing treatment options, including the risks and benefit with their patient in an open awareness context. Now we know the importance of diversity, and actually we can work with people who are in different and various countries now. Even so, it still remains some tend to hesitate to speak up, especially to doctors by patients. So therefore, in this setting in Japan, the team approach, nursing support must be the best solution, I think. As an oncology nurse, I keep supporting that our patient can speak out and what they want to say to healthcare professionals, especially to their doctors. My friend and colleagues, they also have been dedicating to care for patients and keep integrity of our trials. The important thing is how to create care and how to protect for our patient and to live our life safely with positive thinking and resilience. Once again, thank you for all of you to listen to our experience today, and it's my great honor to talk with you all. Thank you very much.
Thank you very much, Noriko. It was a very interesting presentation. It's enlightening to have a nurse's perspectives. Now we will move on to Graciela Zibetti Dalmolin from the Beneficenza Portuguesa de São Paulo Hospital in Brazil. Graciela?
Thank you so much, everyone. Thank you, Daniela. Thank you, Dyson and IGCS for being here. It's a big pleasure to discuss about telemedicine and to represent Brazil and Latin America here. So I'm also a member of a nonprofit organization that's called Lado a Lado pela Vida, and we'll discuss a little bit about the project that we are doing here in Brazil, even before COVID. So just as background, to understand, Brazil is a country with a lot of disparities. It's considered an upper middle income country with continental dimensions, but you also have areas with very low income. We have two health systems, public and private. Public is considered universal for all Brazilians, but the private is used only from a quarter of patients, but almost all financial resources in health are destined to private health. And just to understand better, Brazil is the 50th biggest country in the world, and we have a lot of disparities. And here in the green area is the North region, where we had the Amazon forest, and here in the orange is the Northeast region. These are the most poorest regions in the country, and here in the South and the Southwest, we have the richest regions in the country, And cervical cancer is really high prevalent in the green and orange areas compared to the other regions. And as now with COVID-19, since it's a very big country, is considered now after US and India, the third country in number of cases and deaths in the world. And unfortunately, we now have more than 168,000 deaths. And we're still waiting for the second wave, and our cases and deaths, they had a decline the last few months, but now they started increasing again. And since we had this pandemic here in our country, the lockdown, they started in March, and the first case starting the end of February. So we had a lot of barriers and a lot of problems here in our cancer patients. We had a decrease in clinical appointments, a decrease in cancer screenings. We probably have an increase in more advanced cancer diagnosis soon, since the patients are not going to their doctors. And we had a decrease in all types of immunization, and also include the HPV vaccine. And why telemedicine is so important, especially here in our country? We have regions of rural areas with really hard access, and we have population with few or no access for health professionals, and areas with very few cancer facilities, and disparities in terms of education and general cancer knowledge. And now with COVID-19, we have the pandemic showed all the Brazilian difficulties and disparities for all the population. So we had in the last months an increase in tumor boards online, webinars, and after a few months in private health, we had an increase in telemedicine and telehealth. But unfortunately, we don't have a legal regulation for telemedicine in public health. And this is a project that we worked in this nonprofit organization. And this happened the last year before COVID. It was a project that took place in 2 communities in the Amazon forest in the Blue November last year, in rural areas with really hard and arduous access. So doctors and all the male population, they were together through a live video streaming. And all the male population, they interacted directly with doctors and discussed their doubts regarding male cancer diagnosis and prevention, since this occurred in the November, the Blue November, a month here that we always discuss about male cancer. And now we're looking for funding to do the same actions for female tumors. So we had all this population here discussing with a doctor from a big center, big cancer center, discussing all their doubts and all about cancer diagnosis and prevention. And how can we replicate those actions? So more low and income countries, they had the same similarity of scarce resources and a high prevalence of cervical cancer. So discussions like here today with IGCS partnership are really wonderful, and I really believe that we can change our field doing these connections. We can create connections with leaders in different regions, and we can replicate this project in different countries, transposable to other communities. And we don't need to wait COVID to end or stop doing this after we have the end of this pandemic. So telemedicine, I think, is something that came to change the health system, and we are part of this, and we can help a lot of people with this. So thank you very much. This is my presentation, and hopefully we can discuss more later.
Thank you very much. So great information, Graciela. I'd like very much your idea to replicate this project in different countries. Thank you. So we have one more outstanding panelist, Kimberly Hashing from Center of Community Alliance for Research and Education, City of Hope National Medical Center in the United States. Kimberly?
Good day, and thank you so much for including me in this very critical talk. So I'm Kimberly Tam Ashing, professor at the Beckman Research Institute at City of Hope. It's a comprehensive cancer center. And I focus my work on survivorship and community engagement, targeting health equity and health disparities among ethnic minorities and linguistic minority population. In response to existing and even growing health disparities, City of Hope founded CCARE. CCARE is an advocate-engaged, community-minded center with the primary mission of improving community health. Our approach is to listen, learn, feel, and respond with community-informed solutions to reduce the burden of cancer and other illnesses, increase health advocacy and efficacy, facilitate health care and medical studies access, including clinical trials, and improve health and well-being. The COVID-19 pandemic has highlighted the health disparities and the deleterious health, human, and economic price of health segregation and discrimination. The COVID-19 pandemic underscores the need for prioritizing global health and telehealth. Most underserved persons have smartphones, but the lack of the most advanced equipment can be a barrier to telehealth and telemedicine. This requires giving devices to persons and or developing a community loaner library program. They may also lack the know-how of the equipment utilization. So it's used as a phone for more telephonic capacity, but not in terms of using apps and other video conferencing technology for health services. And therefore, capacity building training is necessary. Often communities may lack the monies for the best data plans, and this requires funding. There's also issues with lack of connectivity, requiring communication infrastructure, and that goes into not only the health system structure, but the political and governmental structures that will facilitate communication infrastructure in the country. Communication technology practices. Consider the technology. The platform you use can support or hinder the ability to connect with and engage your audience. Keep the technology simple, avoid videos, screen sharing, and breakout rooms. Establish a structure. Review overall goals, commitments, and share the agenda so people know the structure and the format. Set up group norms and expectations, and please establish the ground rules, in particular, privacy and confidentiality. Lecture less, presenting the information in less didactic ways to keep the patient and audience engaged. Use infographics where possible. Most platforms have chat features, polls, and timers, and document sharing features. Anticipate technology issues. It may be helpful to have a few key phrases handy for when someone loses the phone connectivity or the video freezes. A few sentences explaining what is happening can normalize the interruption. Do have tech support available for you and different facilitator roles. So one could be the lead facilitator and have a tech support who can help your audience with connectivity issues. So the Zoom interpretation channel is a new feature that allows for real-time transcription, meeting notes, that also allows for interpretation so that the lecture could be delivered in multiple languages. Telehealth humility. And these are the norms and practices of good communication in general, but particularly important in this virtual world. Be respectful, kind, compassionate, and nurture trust. Be non-judgmental and unbiased. There are often situations where the patient or the audience may not want to use video. There may be embarrassment in terms of their living condition and situation. And please be very respectful of these contexts. Be culturally, sociologically, linguistically, and community responsive. Foster open communication, patient engagement, activation, and shared decision making. And this can be done by pausing, asking the patient if there are any questions, any concerns. You're happy to explain further. You see them as partners in their care. Encourage them to invite a care provider or a family member if that seems to be an important part of their health and well-being. Be open to cultural norms as well as gender-related issues in the family and the households. Embrace a patient-centered approach. Be considerate of mental health issues and needs of the patient. Encourage adaptive, culturally appropriate, patient-driven coping. That may include spirituality. Encourage self-management for symptoms. And these may include meditation for stress reduction and pain management. I'm adapting a saying by our famous poet, Maya Angelou. The will for quality care recognizes no barriers. It jumps hurdles, leaps fences, penetrates walls to arrive at its destination with health improvements and full of hope. Thank you.
Thank you, Kim Lin. Great presentation. Thank you very much. Now, I'd like to open the panel discussion and questions and answer session. Remember to continue to submit your questions through the Q&A feature at the bottom of your screen, please. So we start with a questions for Miriam. So Miriam, what are barriers to telehealth that patients experience, especially in rural communities and in low resource setting?
Thanks, Daniela. I think the main barriers have been, I guess, highlighted over the course of the discussions today, but I think key are one, the cost, which is, of course, we have good networks in remote areas, and so that in itself is a barrier. And then access to smartphones, and then once you get beyond that barrier, then you go to personal barriers, such as around, as I said, health literacy and knowledge around the ability to use the smartphones. And so those tend to be, I think, the major barriers that affect people. And then the third barriers, as I mentioned, is we have quite a number of dialects. We do have two national languages, English and Swahili, but there's over about anywhere between 40 to 50 dialects. And so not everyone necessarily speaks English or Swahili. So now trying to get something that's culturally appropriate or that they'll be able to understand or that's for them, all these concerns do actually form significant barriers to these kind of services. Thank you.
Thank you, Miriam. So a questions for Karen. Karen, for your great work, how can you encourage and support more women to be advocates for themselves and their communities, Karen?
Thank you. I do know that back at the time when I was going through my experiences, the education wasn't broad. Nowadays, it's reaching people, not completely, but it's working through the schools, through the clinics. IHS is doing their best to reach as many people as possible. And they also have programs, like I had mentioned before, the one I was involved with, to do an outreach, not only on my reservation, but they do it countrywide, and they share as much information as possible. I do know that it'll be hard for some people to get the information because, again, no transportation, no internet service, let alone electricity in most areas on my reservation, as I assume it is on other reservations as well. My husband's reservation, when I had mentioned I had gone to Montana for treatment as well, it's that way on my husband's reservation too. Some people live out in the middle of nowhere, so it is hard in some cases to get electricity, let alone internet service out there. But they are trying to reach as many people as possible, especially when they are actually able to come in and get services that they need. So they're really good at sharing as much information as possible. And the information that is out there, presentations, online services, once they get to a clinic, they can share those things with them. Pamphlet information, brochures. It does reach the people once they're able to get to to get the attention that they need, the medical services that they need.
Thank you, Karen, for your great work. Thank you very much.
Thank you. Thank you.
So I have another question for Gwen. So are patients satisfied with telemedicine attention? Should they be? What do you think?
I was actually just thinking about this when Karen was speaking and when Miriam was speaking. I think that you have to apply all of the kind of principles and values and ethics of working in person through telemedicine. And I think you can create a relationship, but it's a different relationship. And I think you have to also acknowledge that things are different. When you acknowledge that things are different, I think that helps open up the conversation. I think we can't underestimate what the being in the presence of another person is. What happens when somebody puts their hand on your arm? What happens when somebody can look you in the eye? But I think that if you acknowledge and you start from the perspective of this is different, this is strange, but I am truly listening to you. And then you create that kind of conversation where there is a feedback loop or you're actively listening. So you repeat things to people that they've said. I think you can help alleviate. I don't think that you can ever change that relationship. I think the other thing that's difficult is if you don't have a relationship in the beginning already, creating a relationship on the phone is more difficult. But I would also say, just to add, a lot of patient advocacy in the beginning started with people on listservs, started with people who weren't meeting face-to-face. And there were very deep relationships that were created for people who hadn't met for years. So satisfied, maybe not, but I think that it can be, completely satisfied, but I think it can be effective and it can be therapeutic.
Okay, thank you very much, Gwen. So we have a question from the audience for Noriko. Noriko, how the Japanese patients to become not leave the decision to doctors?
Thank you. Thank you for a great question to me. And it's very difficult to find the answer, right answer, because, yes, as you know, Japanese, we have a lot of hospitals, that means, and free access to the doctors. So it's difficult to doctors, think want to keep their time to discuss to the patient, but it's difficult to keep their time. Average time for doctor consultation is 3 minutes or 4 minutes per patient. Very short time, so it's really struggle. So it's the Japanese patient some patient advocacy group educate the patient to summarize their question before doctor consultation. And then they try to talk with doctors very briefly. And then we, nurses will support to the patient, ask their, what they want to have, what they want to talk, doctors. And now we are now slightly opened the conversation, but it's difficult. Honestly, it's difficult. Is the right answer? Thank you for your great question.
Thank you, Noriko. And the next question for Graciela. Graciela, how do you communicate bad news through telemedicine? Because it's really difficult in Italy.
It's a great question. Thank you, Daniela. And Brazilians are like Italians. I don't think they're satisfied with telemedicine because we like touching, kissing, hugging. We're really emotional. And I think this physical is hard for culture. So I had to face this online, doing bad, giving bad notices, and I think it's really harder for the doctor. And that's how Wing said, you need to take all your care and humanity to a computer, and it's not easy. And you need to say that it's not the same thing. And I always say, I really would like to be here with you, but I can't. And hopefully I can hug you later. And I think you need to try in a hard way. You need to connect with your patient and say that even if you're not physical close, you are close in some way. But this is the hardest thing in oncology now with COVID, I think.
Thank you very much. So another question for Kimlin. So what do you think about, there is some tools to help in decision medicine, in decision making, the patient and the physician?
Yeah, I think there are several tools actually that are available online. I think Cancer Care is one organization that promotes, advocacy, engagement, whether it's telemedicine or face-to-face delivery. I think Gwen's organization is another key advocate organization that can, help patients be engaged. I think one of the things that is important for patient engagement, it really is the burden upon the health system and the healthcare providers to give the patient not only permission, but really welcome them to participate and give their feedback on their care, what's important to them in terms of their care and their outcome. For some people, it's length of life and they want every treatment available. And for some people, it's quality of life. And so if there's going to be severe side effects, they may make that personal decision to avoid that, then that needs to be supported. I think culturally, some people and within their family systems, they may want to have multiple people be engaged in part of that, care decision making. Those need to be, acknowledged and welcome and respected. And I think it's a difficult situation in the U.S. as well as other countries. Noriko said, 3 minutes for a visit. I think that makes it very complicated in terms of delivering quality health care. So I think we need to engage nurses in, nurses are a wonderful underutilized resource in delivery of very good care. And they have both the medical knowledge as well as, the patient rapport that can really help healthcare systems and hospitals deliver better care for patients.
Thank you very much. So I saw we have Kadia Bambu in our virtual attendees. So she worked on project Pink Blue. I know Pink Blue for the previous advocacy summit of AGCS last September. And I want to thank all people like her that work with force and constants. So we have only a few minutes left. So I would like to give to each panelist an opportunity to share brief closing remarks, just 1 sentence, and as a message for our attendees. Gwen?
I'm sorry, I was listening and waiting for the first person to talk, and that would be me. So I think one of the challenges of the pandemic and telehealth and telemedicine is to think about what you can do, what are essential things that you need to do that are in person. And one of the things that people have been working on, particularly in the oncology space in the US, is what visits need to be in person and how to make those visits safe. And then what visits can be done and can be done by telemedicine. What can be safely, what are essential services? What can safely be put off? So I will tell you a personal anecdote. I put off a follow-up appointment, but I called the nurse, and the nurse and I talked about it. This was for my gynecological cancer. And she said, "You're feeling well, you have no symptoms. Let's wait another 2-3 months until we ensure that it's safe to come into the office." I did, and I felt so much better. But it was about shared decision-making. It was about having this relationship with my healthcare provider that I could ask those questions. So I think we balance. There are things that have to be in person, and there are things that can be done through a relationship and a conversation like that.
Thank you. Miriam, your message.
Thank you. Thank you, Daniela. I would say my message is that communication is key. And irrespective of the vehicle, whether it's telemedicine, telehealth, whether it's in-person, communication. Now, communication does involve active listening, because if you're just sitting there and sort of thinking you're going to finish and go through, this is what I want to do, but active listening implies or compels you to take a step back and listen to, where is this person coming from? How can I do, what would I do if they were in their shoes? And just, willing to take the time to walk that journey. So irrespective of the vehicle, yes, you may not be able to hug, as Gabriella says, but perhaps you can do a virtual hug and actually make that experience quite enriching for the patient. So that would be my message.
Thank you, Miriam. And Karen, your short message.
Thank you, Daniela. I would like to say that in my culture, I do understand that the people, especially those who still live traditionally, have a hard time speaking about their health, even if it's just a little cold. I would try to encourage them to try and reach out and talk about what they're going through, what it is that they need. and that it is okay to share and talk about these things. And it is actually necessary for them to do this so that they can receive, so they can find out and receive the attention that they need. And once they are able to get that attention, that they'll be able to get a chance to get to other resources that are available. I do know that resources are scarce on reservations, but there is probably a possibility that they will be able to reach other people who know of other resources that are available elsewhere. It's important to talk and keep communication lines open with healthcare providers. And again, I'd like to thank IGS and IGCS, and especially you, Daniela, for moderating the presentation here. I appreciate all the information that all has shared, and it's still a very well learning experience, and I appreciate all the time. Thank you.
Thank you, Karen, to you. And Noriko, your message?
Thank you. Thankfully, many people give healthcare professionals the very kind words. You are frontliner, or you are great, or something like that. But I think we are all frontliner in this difficult situation. So we think together to through a difficult situation. Not only nurses, not only doctors, and I think we can move forward to our future together, like these sessions, this program, great program. So it's very my honor to attend here and talk with all of you, panelists and organizer and audience also. Thank you very much.
Thank you, Noriko. And Graziella?
Thank you again, everyone. And I believe the COVID-19 told us that telehealth can decrease health disparities, and we can increase the communication even in rural and hard areas. So I believe that telemedicine won't stop after the pandemic. So we should see more about this as healthcare providers, politicians. How can we manage telemedicine to decrease disparities in the world? Thank you, IGCS, for this great, great panel.
Thank you to you, Graziella. And last but not least, Kim Lin.
Yes, COVID-19 has been a horrific pandemic. In the US, there are, 12.2 million cases and over 250,000 deaths. But it has brought the opportunity of addressing health disparities through telemedicine. I think we need to broaden who delivers telemedicine: physicians, nurses, social workers, psychologists addressing mental health issues, the adequate training of patient navigators who can help increase opportunities for completion of home test kits, like cervical cancer home test kits. The FIT tests for colon rectal cancer can be increased by the use of navigators through telemedicine. So we have an opportunities to increase the delivery of healthcare, breaking down the barriers of transportation and rurality, and really addressing health disparities through telemedicine. And I thank all the panelists. I've learned a lot, and I do look forward when one day we can get together at a conference, including all the attendees, and we can hug and eat together and continue to learn from each other. So thank you.
Thank you, Kim Lin. So the last questions, just to thinking for all panelists. So about taking the health inequality of telemedicine, how do we tackle affordability, connection, and competency of technology? We don't answer now, but we're thinking forward. So as this great session comes to close, I want to thank each of our panelists for their time, expertise, and insight today. I would also like to thank all of your for attending, for spending part of your Saturday with us, learning more about telehealth, telemedicine, and shared decision making. And we want to thank our sponsor, GSK. This is the first roundtable in a 4-part series that GSK is sponsoring. So please let us know what other topics are important to you. Just email to Daisy Scroggins at daisy.scroggins@igcs.org with suggestions or comments, and we will forward information on the coming roundtables soon. And shortly, you will receive an email providing a link to the recording of this roundtable. Again, we thank our panelists, all who attended, and our sponsor for joining us at this table. We wish you all continued health and safety. Take care, stay safe. Thank you very much.
Thank you.
Thank you. Be safe and well.
Thank you, everyone.